Today, I'm thrilled to have the opportunity to introduce our speaker, Dr. Yarden Fraiman. Dr. Fraiman was born in Chicago, Illinois, and completed his medical degree at Johns Hopkins. He then went on to complete his pediatrics residency at Boston Children's and his NICU fellowship at Harvard. He also did an additional research fellowship during his neonatology training. He went back to receive his master's in public health at Harvard in 2021. His current research includes examining neighborhood drivers of racial and ethnic disparities along the early intervention care cascade for very preterm infants in Massachusetts, understanding disparities in genomic medicine, and assessing implementation of a healthcare racial justice assessment tool. Along with his clinical and research duties, he's an active educator of residents, fellows, and medical students. Today, Dr. Fraiman will be presenting his talk entitled Promoting Health Equity in the NICU, Multi-Level Approaches to Achieving Health Justice. As a reminder, please stay muted and type questions into the chat, which I will read at the conclusion of the talk. And please fill out the survey at the end of the talk via the red cap link in the chat or using the QR code, which will be displayed at the conclusion. And with that, I will welcome Dr. Fraiman to get started.
Thank you so much for the kind introduction and invitation. I'm just going to see if I can move. For the kind introduction, I'm super excited to be talking to you guys and very thankful to Deirdre for the invitation. Before I begin, I always like to begin with a customary land acknowledgement and acknowledge that Harvard and the Longwood campus sits on the original homelands of the Wampanoag, Nipmuc, and the Massachusetts nations. I acknowledge them as the original stewards of this land and recognize their absence as the result of their forced removal and ethnocide. I recognize that the ever-present inequities they experience stem directly from past violence, forced migration, disenfranchisement, and ethnocide. And furthermore, as the heirs to that legacy, I recognize our important collective role in reckoning with the past and promoting and securing justice for the future. And I want to take a moment to think about that word heir, specifically acknowledging that we are the heirs to that legacy. As Isabel Wilkerson says, we didn't build the house, but the parts that we are ignoring will never go away. And so it is our responsibility to really reckon with that. I also want to go ahead and make a personal acknowledgement and acknowledge my own identity as white, Latino, first-generation American, as the child of immigrants and the grandchild of refugees, as a gay, cisgender Jewish man, and acknowledge that those intersectional parts of my identity give me both power and privilege, being white and a cisgendered man, and also disenfranchise me as being Latino and first-generation American, and that those different parts of my identity contribute to how and why I do this work, to my own lens and my own biases. So a quick content overview about what we're going to be talking about today. I'm going to briefly start by talking about inequities in the NICU, and then transition to thinking about race and racism, and specifically how we integrate those concepts into existing conceptual frameworks, specifically the social ecological model, and then really hammer down into how we create multi-level change. Right? One, by showing an example through research that kind of uses a multi-level research paradigm. And then secondly, by actually highlighting some of the work that we're doing here at the BI that's really focused on addressing racism at multiple levels at the same time. So jumping right into inequities in the NICU. This for me is the paper that kind of launched the field. This paper that came out in 1997 in the New England Journal of Medicine by Richard David and Jimmy Collins, that really put out there that the disparities or the differences that were being seen in birth weight between Black and white infants was an inequity, right? It wasn't due to biology or genetics, but was really the result of something unique that was happening in the US. And what they did, for those of you that don't know, is that they looked at birth weight distributions of US-born white infants, infants born to US-born white individuals, and Black infants born to US-born individuals, and then Black infants born to African-born individuals, and saw that the birth weight inequity really only applied to infants born to US-born birthing people. And so that really highlighted that there was something unique that wasn't biology or genetics that was causing this inequity. And this study gave way to a future study that actually looked at multi-generationally these families using data in Illinois that found that the inequities that were not there among African-born or infants born to African-born birthing people actually emerged, and that the positive trends reversed in that population. And again, signaling to us that there was nothing really about biology or genetics that was causing these differences or disparities, but that these were really inequities that were unjust. And I really want to be thoughtful about the way, and I try to be thoughtful about the way I use the word disparity versus inequity. And since then, we've had so much work come out, right? Work from Erica Edwards and Jeffrey Horbar and Vaughn looking at outcomes in 30-week in our tiniest babies that we take care of. We have work that's looked at quality, both objective metrics of quality from Yoke Profits Group, and then also in qualitative inequities that parents report on. We also have papers that have come out and research that's come out that looked at a myriad of different outcomes. The provision of human milk is obviously one that is near and dear to our neonatal hearts. This work led by Meg Parker and many of my colleagues here in Boston. And then again, work from Yoke and Profit looking at the systematic review of existing data. And there's work that's coming out of people trying to ask the question, why, right? So work from Elizabeth Howell's group in New York, looking at the role of hospitals in the inequities that they were seeing, and from Erica Edwards and Jeffrey Horbar, again from the Vaughn group, looking at racial segregation within NICUs and the ways in which this contributes to the inequities that are being seen. And so all to say, right, that at the end of the day, inequity exists in the NICU. This isn't new for any of us that are in this talk or for any of us who are practicing neonatology. But the question that I think we need to come out and ask is really, why do inequities exist, right? How can we move from a mindset of here's another disparity, another difference, right, to why do these inequities exist, right? What's upstream of this? And more importantly, when we orient ourselves to think about why inequities exist, can we really begin to ask the more meaningful question, in my opinion, which is, how can I create change, right? And so that's going to transition us to, the next topic here, which is race, racism, and conceptual frameworks. Now, for many of us doing this work, we understand that when we look upstream, right, when we actually see this data and we see that there are racial and ethnic inequities, starting from Jimmy Collins' work all the way down to the work that's being done now, when you look upstream, the driver of inequities is racism. And so in order to understand that, we need to think specifically about what race is and how it's operating. So I like this definition from Nancy Krieger. She's a professor at the T.H. Chan School of Public Health here in Boston. And she says, race is a social, not biologic category, referring to social groups often sharing cultural heritage and ancestry that are forged by oppressive systems of race relations, justified by ideology in which one group benefits from dominating other groups. And she goes on to say that race leads to the enforced marginalization of people from positions of power, coupled with the assumption that white, economically secure, I would argue cisgendered men, are allegedly the norm. Now, what I like about this definition is that it brings together a lot of the key concepts about race, that it's a social construct, that it's neither biologic or genetic, but it does bring in these important concepts of shared cultural heritage and ancestry. Importantly, it brings together two major concepts that are crucial to understanding how race operates. One, that it is based on a system of oppressive systems of race relations, right? Thinking specifically about the ways in which hierarchies are built and the way in which power is hoarded, right? And the other is the piece of normalization, right? This normalization that white economically secure men in this definition are allegedly the norm, and that everyone else is not the norm, right? When we think about a reference category, right, this is where this comes from, and this is super important in understanding how race operates. So when we think about publishing on race, or when we look at data or think about what it actually means, already journals have started to take these ideas and integrate it into what they are asking scholars to do. So when we look at the journal at Pediatrics, right, and we ask them what we should be doing when we use race or ethnicity, they're very clear, right? Results related to race and or ethnicity should be interpreted in the context of racism, right? So a very clear move away from the biologic fallacy of race toward understanding that differences or inequities seen that are racialized are a result of racism. Now, when I talk about racism, I'm talking about a complex system. Now, growing up, racism was taught to me that it was just when bad people do bad things to other people. But what we have come to learn is that racism actually operates at a much broader scale, and it's much more complex. And we typically think about it in these four categories: institutional racism, structural racism, interpersonal racism, and internalized racism. Now, I'm going to take a little bit of time here and dive deeper into each one of these, because these provide the foundation for understanding what I mean when I say multi-level, okay? So if we start at the bottom left-hand corner at institutional racism. Institutional racism is the racism that we typically think of as embedded in laws and policies in society. I display here the book, The Color of Law, which is a book by Richard Rothstein, where he really highlights the ways in which the legal system enforced racial segregation through redlining, and also talks about the system of segregation, of housing segregation, and how it's continued to lead to ongoing inequities in housing. But what I think we typically don't think about is the way institutional racism can operate in other settings, right? So we typically think about laws or the Jim Crow South. But what I think about a lot is the way institutional racism lives in the hospital, because that's our institution. That's where we operate, right? So the example that I like to give is the ways in which institutional policies can promote inequity or uphold inequity in ways that seem, without even mentioning race, right? So let's say you worked in a NICU who had PCAs or patient care associates who only were employed during the day. And there's a decision made in the NICU that skin to skin can only happen during the daytime when there's enough staffing, because that's when it's safest. Taking a baby out of the isolette, especially with a breathing tube, or a baby who has tenuous clinical status, needs additional supports, and so it should only happen in the daytime. Now, on the surface, that seems like a totally benign, if not great policy that's promoting infant safety. But when you look at who's disproportionately affected by a policy like that, when you think about who in this country is more likely to be a shift worker, who in this country is more likely to have leave, right? Who's more likely to be able to be at the bedside during the day? Where are hospitals located? How is transportation functioning? Then you realize that the population of people who are disproportionately negatively impacted by this policy are minoritized people. So a policy that on its surface is completely benign, if not promoting safety, may actually be upholding inequity, even though it never says, right, anywhere in it anything about race. And so that's the ways in which I think about institutional racism operating within our NICUs. And I'll talk about this a little bit later on. There's then transitioning to structural racism. Structural racism is the totality of ways in which societies reinforce both discrimination and the normalization of the white experience, right? So in society, we typically think about structural racism as things like housing, employment, the school to prison pipeline. But how do we think about structural racism in the NICU or in our medical education? So for example, in my medical education, I never saw any medical illustrations or any pathology ever shown in a textbook on a non-white body. So what does that mean for me as a neonatologist now practicing medicine? If I've only been taught how to recognize jaundice, for example, on white skin, it may take me longer, despite my best efforts, right, to recognize jaundice on non-white skin, which may lead to inequities in bilirubin or kernicterus, right? If I'm in the delivery room and I can't recognize cyanosis in non-white skin as readily as I can on white skin, despite my best efforts, right, I will not do the same for two babies, right? And so that's the way we can think about structural racism operating, for example, in the medical education system. Another example is, what does the signage in your NICU look like? Is the signage all in English? If so, how do families that we take care of who don't speak English or read English access the information and the signage? Is that not also structural racism within our clinical settings? Next, moving up as we move counterclockwise, we have interpersonal racism. Interpersonal racism is the kind of classic form of racism that we're taught about, right? Bad people doing bad things to other people. This is where we start thinking about implicit and explicit bias, right? I have here the picture of Christian Cooper, who was a birder in 2020 in Central Park, who had the police called on him for asking a white woman to leash her dog. And so this is like the more classic type of racism. And when we think about these types of interventions that happen here, right, or the ways in which interpersonal racism manifests in our units, right, it's not hard to see how bias and racism can impact the clinical care we provide. And finally, there's internalized racism. Internalized racism, for me, is the most complex and also in some ways the most interesting to address and to think about. But this is when individuals from minoritized groups begin to believe negative stereotypes about themselves. Interestingly, the work done by Claude Steele, a social psychologist at Stanford, actually has demonstrated that when individuals are under a threat of upholding a stereotype, what he calls stereotype threat, they are more likely to underperform. So how does internalized racism show up? You know, for me as a gay man, there are many negative stereotypes about gay men. It means that when I'm in certain spaces where I feel threatened, I may then uphold those stereotypes in more obvious ways or underperform as a result of the fear of that stereotype. And so all four of these are really what we mean when we talk about racism. So when pediatrics says, you know, race and ethnicity is a proxy for racism, situate your results within that context, is that enough? How do you do that? How do you begin to parse that out? And so what I've begun to think about are, what are the conceptual frameworks that exist out there that I already know how to use that I can map racism onto? So the social ecological model that was originated by Bronfenbrenner essentially says that an individual's health, right, is a result of multiple layers of influence, starting from the internalized and individual level to the family, community, neighborhood, and policies and law. And so when you think about these four domains of racism, it is not that hard to see that they might map onto the social ecological levels. And if that's the case, then it becomes much easier to apply methodologies that exist for the social ecological model onto and use them for understanding the different levels of racism. So I'm going to transition now to talking a little bit about research that we've done that's utilized some of these multi-level approaches. But before I do that, I just want to take a pause and see if there are any questions on anything I've talked about so far or in the chat. All right, I will continue going on.
Nothing in the chat, Dr. Fraiman.
Awesome, thank you. So the question we go back to, right, is how do I create change, right? And so I'm going to highlight this article that we published in Pediatrics, not because it's anything so phenomenal, but because I think it begins to scratch at how you can actually look at the different layers and the different levels of racism in a methodologically complex way. So what did we do? We partnered with the Vermont-Oxford Network, and we asked, what roles do hospitals play in driving inequities in high-risk infant follow-up program participation? And just to remind you, and I won't give you much background on this, but high-risk infant follow-up programs or follow-up programs or follow-through programs are programs usually for the highest risk infants after they leave the NICU to have follow-up. And we know that infants who participate in high-risk infant follow-up have better outcomes, right? So this is a key area that I think about. What happens to babies after they leave the NICU. And so we had three hypotheses. One, that there are going to be racial and ethnic inequities in high-risk infant follow-up program participation, that there is significant and measurable variation within and between hospitals, and that hospital-level factors would contribute to variation in participation. So we looked at data from 2006 to 2017. We took all the live ELBW births, and we excluded those that died prior to discharge or their follow-up appointment, or who had an unknown dispo, and that left us with about 22,000 infants. We excluded babies that were born in non-US centers, whose follow-up status was unknown, and who didn't have complete race or ethnicity data. And that left us with about 19,000 infants, 8,712 of them who were seen in follow-up, and 10,790 who were not seen in follow-up. Now, here is where I'm actually going to get to like be really, really nerdy. So I apologize. What did we do? So the data in Vaughan, right, is individuals nested within hospitals, right? So there's a cohort of babies, and they can be, you know, which hospitals they come from. So in some ways, the data structure itself is data structured in levels. So then below that, I have, right, the same conceptual framework I showed earlier, a different schematic of the social ecological model with individuals, interpersonal, community, and public policy. So you can begin to see how your data structure actually mirrors your conceptual framework. So what we did is we used generalized linear mixed effects modeling, or multi-level, multivariable logistic regression. And here is how the data actually helped us, and the structure helped us to think about the way we did this work. So when you do multi-level modeling or generalized linear mixed effects modeling, you start off with a null model to obtain the interclass correlation. And this tells you how much variability in your outcome, in our case, whether you did or did not participate in high-risk infant follow-up, is attributable to each level. Okay, so if level 1 is the individual and level 2 is the hospital, you can say how much of the variability in your outcome is due just to level 2. Okay, the next thing we did is we added infant race into the model. Now, when you do a classic or simple ordinary least squares regression, right, like your straightforward linear or logistic regression, your variables that you put in give you an odds ratio, right? Like if you are female, you are this odds more likely or less likely. Or in my case, when you put race or ethnicity in the model, right, this makes you this or this much more likely to be able to meet your outcome. Now, when you do generalized linear mixed effects modeling, what you actually can do is you get an overall effect in the same way you do with that type of modeling, but you also get the ability to add what's called random slopes into the model. And what that means is that you can say, I'm going to allow the effect of race to vary within each hospital. Why would you want to do that? Well, because we know that race is measuring racism, right? And so racism in Boston and the effect of being minoritized in Boston might be significantly different than the effect of being minoritized in Texas or LA or San Francisco or Chicago, right? And so it acknowledges that what you are looking at is not just an individual level feature of a person, but really measuring and thinking about how is racism operating. So you still get an overall effect of race and ethnicity, but you also get to look at how does the effect of race or ethnicity vary between hospitals. Then you add your patient level covariables, and then you can add hospital level covariables. And again, they exist at different levels. Okay, so what was the outcome of this work? So to orient you to this graph, each one of these circles represents a different hospital in the Vaughan study. And they are ranked from the lowest follow-up rate to the highest, with the y-axis being the percentage of high-risk infant follow-up program participation within that hospital. When we got the ICC, or the interclass correlation, it told us that 26% of the variability in the outcome, 26% of the variability in high-risk infant follow-up program participation was due to hospital alone, right? Think about that. Just what hospital you were born in predicted 26% of the variability in your likelihood to actually attend follow-up. And that kind of makes sense when you see this mapped out like this, right? That while your mean participation across the sample was around 44%, you have hospitals down here that are sending less than 10% of their kids to the follow-up program. And you have programs up here that are sending upwards of 80% of their kids to the follow-up program. And so seeing that is super important. But next, we were able to add race and ethnicity to the model. And again, we did this with a random slopes model. So to orient you to this graph, what we have are the same circles. That's the overall high-risk infant follow-up participation rate at the hospital level. But then we've added here triangles and squares. The triangles represent the high-risk infant follow-up program participation at that hospital for Black infants. And the squares represent the high-risk infant follow-up program participation rate at that hospital for white infants. And so what you can see, right, is that there's a lot of inequity. That in general, the triangles fall below the circles, and above them generally fall squares. So what you can also see, right, is that there's a lot of variability, not just within hospitals, but also the inequity varies across the hospitals, which means that doing this random slopes model shows you that race operates in different ways in different places. So let's look at our results. So we get an overall effective race right here, right? That shows us that if you are Black or Hispanic or Latinx, you have a statistically significantly decreased odds of high-risk infant follow-up program participation across the entire sample, right? But we also have this value here, which is the covariance parameter. The covariance parameter tells us, by being statistically significant, that the effect of race differs significantly between hospitals. It means that context really matters. And right, it allows you to then begin the process of digging in deep and saying, okay, there are programs that have low participation rate overall, but they maybe don't have a lot of inequity. Or maybe there are programs that are doing really well overall and also don't have a lot of inequity. What are these programs doing? You have programs in the middle that are doing a variety of different things. What are those programs doing? How do we begin to dive deeper into understanding the why and not just the, is there a difference? It leads us to stop considering race and starts to force us, when you model in this way, to begin thinking about racism. We then moved on to conduct some subgroup analyses just between Black and white patients who are our highest populations and the rate of follow-up, and essentially showed us that with more ELBW white admissions, as the population within your NICU became more and more white, the rate of follow-up within those hospitals also significantly increased. We also looked at academic hospital, the type, and the number of ELBW admissions annually. And while none of these were significant predictors on their own, right, so it didn't have a p-value of less than 0.05, they significantly improved the model fit and decreased hospital level variance. So if you are not, if you don't bow to the deity of the p less than 0.05 and allow yourself to look at what these things mean, you might say, right, that these are significant drivers because they really decrease the variability in your model. So what does this all really mean? So it means that hospital level, what we found is that hospital level variation exists and contributes to high-risk infant follow-up program participation. That there was a fixed effect of race, that's those big odds ratios, that racial and ethnic inequity exists across the entire sample. And maybe what that is structural racism across the entire United States. That there was also a random effect of race, that's that within hospital variation, within hospital inequity, and that the inequity varied between hospitals, right? That's telling us that racism is contextual and that there's within hospital inequity, right? That even within one hospital, the same infant with the same covariates who have a different race or ethnicity have a different likelihood of attending high-risk infant follow-up programs within that NICU. And so maybe that's looking at interpersonal racism or local institutional or structural racism. And finally, that hospitals with greater white populations have greater high-risk infant follow-up program participation. Maybe that's pointing at institutional racism at a different level, right? Maybe that's about resources, funding, staffing. And I think what I want to highlight here is not just that the model takes these things into account, but the way we talk about them and the way we communicate them to our audiences, to the readership of our journals is super important. So here is how we wrote it. We wrote, the fixed effects of race, consistent across individuals in our sample, may be conceptually understood to represent the impact of structural racism on healthcare utilization. Within hospital inequity may represent local, structural, and institutional racism that may lead to differential high-risk infant follow-up program participation because of in-hospital, maybe lack of social supports, diminished trust, right, distrust, post-discharge decreased clinic accessibility, transportation, limited time off of work. And finally, that within hospital inequities may be due to the effects of interpersonal racism. And that explains how infants within a single NICU may have different likelihoods of high-risk infant follow-up program participation on the basis of race only. And so for me, what I think that this really highlights before moving on is that oftentimes when we see journals say like, oh, when you include race or ethnicity, it needs to be couched within racism or explained within racism, oftentimes people end there and they don't dive deeper. And as physicians, we are trained, right, to see individuals. And so oftentimes we see inequity at the individual level only. How many articles have you seen that you've read that there's inequity, and in the discussion they say, oh, it must be due to the social determinants of health at the individual level, right? And not having the data or not organizing the data or not modeling the data in a way that allows you to think about the different levels, right? That allows you to merge your true understanding of the complexity of racism in your model often leads us to then flatten the concept of racism. And why does this matter? Because individual level interventions to close the health equity gap have never been successful. And yet our research continues to use those approaches, our discussions continue to center individuals, and our interventions, when we think about them, are mostly at the individual level. So what I'm going to do now is change directions, do a pivot, and talk a little bit about how we in Boston at BI are thinking about creating change really on the ground in the NICU. Before I do that, I want to see if there are any additional questions, either in the chat or from individuals that may have come up with the last kind of section on the research, the high-risk infant follow-up program research. All right, I'm going to move on. So going back to this question about like, how can I create change? Now, I return to it because, you know, while I think that the research is important and the research can point us to how to make that change or where to make that change, at the end of the day, most of us are neonatologists who are at the bedside with patients, with families. And so I think it's important to recognize that all of us can be change makers. We wrote a little bit about this with Diana Montoya Williams and others, thinking really, really concretely on how you can be anti-racist, how you can begin to create change to close the equity gap, no matter what you do. Whether you're a researcher, whether you're a medical educator, whether you're a QI expert, whether you're a clinical leader, all of those domains have ways in which you create real and meaningful change for families. So I'm going to talk a little bit about what we're doing, like I said, in Boston. So in 2021, I joined the faculty here at Beth Israel, and we established the Neonatal Health Equity and Justice Subcommittee of our NICU Leadership Council. And this was an interdisciplinary committee that included physicians, nurses, nurse practitioners, our PCAs, social workers, and most importantly, NICU families. And these are some of the areas that we focused on, including universal social determinants of health screening, anti-bias, anti-racism upstander training, racial justice assessment of the NICU, and the collection of accurate race and ethnicity data. And in the middle, you'll see that it says Just Babies because that's the nickname for our committee, Just Babies. So I'm going to dive a little bit deeper into the work that we did, because I think it's important to really see how this work can actually happen within the NICU. So the first thing that we had to do is think about where our race and ethnicity and language data was actually coming from, right? To address inequity, you have to have accurate and complete data. As my clinical chief likes to say, garbage in equals garbage out, right? If you don't have the data, there is just no way that you can know what's actually going on. And so the most accurate race and ethnicity data for infants is based on self-report and the birth certificate, which I don't think is perfect, but it's the best thing we have. So we started by looking at, in the EMR, how accurate and how complete was our race and ethnicity data. So in May of 22, so this is, just to orient you, every bar is a different month over a full calendar year. The different colors represent the different race and ethnicity categories. And what I want you to focus on is this blue line. This blue line represents the percent unknown in the EMR of race and ethnicity data. So when we started looking, what we saw was that there was about 25% missingness. Why does this matter? So there's no way you can stratify your results. There's no way you can stratify your outcomes, whether it's NEC or BPD or IVH or admission temperature or skin to skin or the provision of human milk, if you don't have complete data, right? Garbage in equals garbage out. And so what we started to do was a quality improvement project to improve our race and ethnicity data so that we can actually do the real and meaningful work. And over the course of 4 months, our missingness data dropped to between 1% and 5%, usually sitting around like the 3% mark. This is pretty great. And this is for inborn babies. Most recently, we've actually partnered with our statewide perinatal quality collaborative to actually have the birth certificate data sent back to us with demographic information, so we can also make sure that it's not just complete, but that it's accurate, right? Because there's a lot of data out there that shows that the EMR demographic data is fairly inaccurate. So now in, where are we? April of 2024, we have nearly complete and accurate race and ethnicity data for all of our patients. Now, I think a lot of institutions are really focused on the collection of real data, real being race, ethnicity, and language data. And I just want to be clear, like that data getting to this point of missingness is only the beginning, right? And I think often healthcare systems are applauding themselves from getting down here, but maybe not using the data for what it's really important to use it for, to begin to look at where inequity is in an accurate and meaningful way and to dive deep, right? Using the quality improvement methodology and the implementation science methodology that experts in clinical departments already have to begin to ask questions on inequity. The next project that I'm super excited about that we're doing here at the BI is a racial justice assessment of the NICU. So in the last couple of years, there have been a number of tools that have emerged trying to measure and highlight structural racism in different settings. And they mainly exist, is what we realized, in the corporate sector, right? And in the nonprofit sector, but they don't exist yet in the healthcare setting. And we were really interested in how we could measure and address structural and institutional racism in the NICU, because what gets measured is what gets done. And if you can't measure the structural racism or institutional racism in your clinical setting, you're not going to be able to create an intervention for it. So what we did is we did a literature search trying to identify all of the existing racial justice assessment tools, and using an interdisciplinary approach that included physicians and nurses and unit coordinators and families, we came together and made what we called the HCRJAT, or the Healthcare Racial Justice Assessment Tool. The key things that were really important for us were that it was easy to use, that it directed toward tangible areas of improvement, and could be used repetitively and iteratively to show improvement. So how did we do those things? First, the easy to use. So all the questions are answered in a red, yellow, green, or I don't know. Easy, simple. That red, yellow, green then gives you a heat map of your NICU to show you where and how the inequity sits. The second was it directs us toward tangible areas of improvement. So we did not ask big global questions like, do minoritized individuals feel included or a sense of belonging in your unit? We asked questions that were specific and tangible and that we could change, right? So things like, does the artwork on the walls depict the populations you serve? Do you have a mission or vision that includes equity? Do you have a reporting system that allows individuals to report racial discrimination? And so these questions were pulled from existing tools that were out there and ultimately led to what we created, which is our 60-question inventory of structural and institutional racism in the clinical setting. And it gives you this heat map. So I'm going to show you ours from our first iteration. So you can see each column here is one person's responses. And you can see that there's a lot of variation. Oh, sorry, each column is not one individual responses. They're ordered from gray to red to yellow to green. So you can see the extent of where you are, remembering that gray means I don't know, red means not yet, yellow means in process, and green means complete. And I just want to acknowledge that doing this work is hard. It is hard to look at a heat map of racial justice of the place you work and see it look like this. I want to give a couple of examples of the questions that we asked on this. So there are 4 domains. So under sharing and communicating common goals, does the NICU have a mission statement that incorporates racial equity? Resources to do the work. Does the NICU have compensation for staff of color to acknowledge any additional work they may absorb? Does the NICU have a structure to address issues of racial equity, such as an equity committee? Does the NICU have a deliberate plan to develop and promote leadership of staff of color? Under community involvement, is there a way the NICU assesses overall satisfaction among minoritized communities within your organization? And patient-focused, does the NICU allow patients and families to self-identify their race and ethnicity? Or is there a process to evaluate whether current policies disadvantage people of color? So you can see that each question, each item directs you to exactly what the intervention is. But it is finally highlighting and putting the magnifying glass not on individuals, right? But really on the unit, on the structural and institutional racism. So the interventions that we are working on are, we've created a equity mission and vision. We are reevaluating the art on the walls. We are translating the signage in our NICU. We just had a meeting with our family partners, going through the picture tours of our NICU and identifying the high priority signs for families to be translated into the languages of the families that we serve in our NICU. And finally, you'll notice that in our heat map, there's a lot of gray, a lot of areas that are I don't know, right? And what that really highlights is that while there may be things that are going on, there's a lot of information hoarding. And that is also structural racism. And so we've created a method to do a PSA on all of the equity work and equity resources that are available, so people aren't sitting in the gray, because gray is essentially red for me. Moving on, I just want to highlight the upstandard and anti-bias, anti-racism training that we're doing. So this is a curriculum that was designed by myself and my colleague Connie Clausen. It covers a whole lot of topics, including a history of race, understanding race and racism, bias. Everyone in the class takes an implicit association test right there, right? A test of one's own implicit bias. And then we end with some upstander training. And what we did is we didn't just say like, oh, this is a class that's offered, right? Because so often who comes to these classes are people who don't need them, right? Or who already have the information. Instead, what we did is we partnered with our leadership to integrate it into every new hire orientation. So every new person who is patient-facing gets this class. And it is now part of our NRP recertification process. So if you recertify NRP at the BI, which most of our staff do, they have a 1-hour lecture as part of their NRP recertification time that is looking at this. So yes, it's an individual level intervention, right? But it is also an institutional and structural intervention. So we gather data pre, post, and at 3 months. And I'll just highlight 3 of the outcomes we looked at. The first is I know the difference between implicit and explicit bias. Prior to the curriculum, only 46% of people knew the difference. At the end of the curriculum, nearly 199%. And 3 months later, 93% of individuals still knew the difference. So you see that there's retention of knowledge longitudinally. When we asked about whether people could identify at least 2 inequities in the NICU, only 49% of individuals could, but by the end of the curriculum, 97 could. And there was some attrition to 87%. And then what to me is the most exciting is I have strategies and tools to address bias and racism in my workplace. So that went from 60% before to 98.8% after, so nearly 100% of people. And in 3 months, 91% of individuals still reported that they had strategies to address bias or racism or discrimination in their workplace. So for me, this is a win, right? At the individual level, but also at the structural level, the amount of people who have passed through this curriculum. We also asked the amount of people who had taken an IAT went from 24% to nearly 93%. And at 3 months, 87% said they still remembered their results. And nearly 100% of people said the curriculum was educational, important, and would change their approach with patients. So when we go back to this schematic and we think about the types of interventions we do and the way we do this work, we can start to see that the real data and equity-focused quality improvement is happening at the institutional level, that the RJAT work, the racial justice assessment work is happening at the structural level, that the trainings happen at the interpersonal level, right? But they're also happening as a result of institutional policy change around trainings. And then the inclusion of families in this work, the valuing their opinions and their expertise in lived experience may also be addressing internalized racism. So I'm nearly at the end. I hope we have some time for questions. Just to conclude that we know that inequity exists in the NICU, but we need to start asking why, because that orients us or should orient us to exploring racism at multiple levels, and to remember that you can measure, research, explore, identify, and intervene at multiple levels at the same time. I'm just going to put up here a slide with not nearly all of the collaborators I work with, but this work is multidisciplinary work. It is the most important way you do this work, in my opinion, and families centered in the intervention work maximally. I have my email up there. I'm always happy to talk to people and hear about their ideas, to partner in research, to collaborate. So thank you again. I'm going to throw up the ONTPD last slide, and we'll have hopefully some time for questions.
Thank you so much, Dr. Fraiman. That was an incredible lecture. If anyone has questions, you can feel free to either type them into the chat or raise your hand, and I can unmute you if you'd like to speak. I had a question while we're kind of just getting things started. Dr. Fraiman, what did you find, during your training, and for us as fellows, where did you find the most bang for your buck, or where do you think is the area that we can affect change the most during our training?
It's such a good question. You know, fellows are the frontline providers in most NICUs, right? They are the ones who are spending the most time with families at the bedside, spending the most time interfacing with patients and families and nurses and respiratory. And so what I have noticed in our program is our fellows get a ton of education on, the pool caps trial and the importance of CPAP and caffeine and BPD and preventing neck and the importance of the use of donor breast milk. And I think that as a result of that, like what I see is our fellows do a great job teaching about those topics at the bedside to the team, right? Especially when you're trying to introduce something new. But I think recognizing that if you familiarize yourself with the data that's out there, you can be true and meaningful advocates at the bedside. And that is hard work, like, right? Like it is hard to speak up about these issues. It can feel really scary. And I think having the data, right? Having said, like, I dove into the literature and actually, like, I want to make sure that this patient has the referral to high-risk infant follow-up because I know there's a study that shows that there's an inequity here. So, like, I'm really focused on that, right? So diving deep into the literature in the training stage so that you can be advocates at the bedside, I think is probably one of the biggest impacts you can have on the culture in a unit. I also find that the fellows, they push us to like, I don't know, Deirdre, you can agree, but I feel like they push me to think about things in new and different and unique ways, right? And so I think asking questions about what you see, why are things done this way? Why is it that we only do skin to skin during the daytime? Who does that affect, right? Asking those questions can be really, really powerful for NICUs.
I was going to ask a question that dovetails a little bit with that, which is, what is your advice about the current climate of I don't know, for me, it's definitely real backlash against DEI and these initiatives to really, be thoughtful about justice and about the way we deliver patient care. I know I have some colleagues in some states that are not as progressive as Massachusetts or Vermont, where I am, where they have to be very careful to not even discuss these issues out loud. So what's your sense about how to embrace this and continue to really work hard as you advocate for?
Yeah, I think I think it's a very troubling place we are in now. And I think the advice I got 3 years ago by one of my professors, Joan Reed, was like, the window of opportunity is open. Go through it as fast as you can and go as far as you can right now because the window of opportunity will not be open forever. And I think we are seeing that. I think that in those climates where it is harder to do intervention work at the institutional or structural level, not forgetting the power you have to sit with a family, right? To have a family be seen. Because in those spaces and in those states, I imagine that it is not only hard to do this work, but it is also hard to exist as a minoritized individual. And so taking the extra time to think about, right, equality is the same for everyone and equity is getting what is needed. And so maybe you spend a little bit of extra time with a family who might need it. And that not forgetting that, while I look at the structural and institutional level as my main lever that I pull, the impact we have on families at the bedside is very, very important.
There's a question in the chat. They said, thank you so much for this great presentation. Would you be willing to share the racial justice assessment? I lead our NICU's Health Equity Task Force, and I think it could be really useful here.
Yeah, we're in the process of writing it up, and then it will be like widely disseminated. Shoot me an email and we can figure out how we can share it. Absolutely. Like this work is collaborative and it doesn't work if we're not all working toward the same goal.
Yeah, and I can also put in a plug for people who are interested in neonatal justice and issues around this. There's a Neonatal Justice Collaborative, which is a national group. And people can also email me if people are interested in both participating in that as well as just hearing about publications or other issues around these, the type of excellent research that Dr. Fraiman is doing.
And I'll just say that NJC is also a great place for trainees that are on the call. And there's a lot of leadership opportunities also for trainees within the national organization.
Okay, we just have a few minutes left. I don't see anything else in the chat, but if anyone would like to ask a last minute question, feel free to raise your hand.
Thank you so much, everyone, for coming and for the questions you've asked. I really appreciated it. And like I said, I'm easy to find, and my email is always available for anyone who wants to chat or collaborate. I'm always happy. This work, like I said, it happens when we work together.